Topic will be about other set of tubular disorders, which is Bartter, Gitelman, Liddles. See, Bartter, Gitelman, Liddles are channelopathies which will cause hypokalemic metabolic alkalosis. We studied metabolic acidosis where there is salt wasting and there is hyperaldosteronism in type 1 and type 2, but it causes metabolic acidosis. Here it is going to cause metabolic acidosis. We'll see Bartter, Gitelman and Liddle syndrome. Now, before you know that, see, Bartter is due to defect in the thick ascending loop of Henle. Gitelman is the defect in the DCT, and Liddle's is due to the defect in the collecting duct. So the first thing we're going to talk about is Gitelman, because Gitelman is comparatively we'll talk about Bartter itself. Not so big. Okay, so Bartter is because of the defect in the thick ascending loop of Henle, sodium potassium 2 chloride. Apart from that, there is a defect in ROMP and chloride. See, if there is a defect in the ROMP and the chloride, what happens is that there will be more of potassium loss and chloride loss. See, also, tubular disorders, the main hallmark is salt wasting. So, since there is a salt wasting, you will have obviously there will be water loss and the plasma volume will be less. So, RAS will be activated and renin will be more and aldosterone will be more. It can be normal or low. BP is nothing to do with RAS. You know that. So, there is secondary aldosteronism because of ENaC activation. But in secondary aldosterone, what happens? Potassium loss is there and H plus also is lost. So, you will have hypokalemic alkalosis. Patient may have salt. What are the how will the patient present? That you should, it's important, right? Always told you always. First, in perinatal itself, you will have polyhydramnios. You can think of many things. Renal agenesis or renal everything, but once a baby is born, there will be failure to thrive, there will be severe dehydration, and when you see the electrolytes, there will be severe hypokalemia. Also, you'll have polyuria, poor cry, and sluggish motor reflex. Apart from that, when a patient presents with sensory neural hearing loss, and also this increased renal calculi. Now, renal calculi, you can also see it in RTA type 1, but it is not acidosis. This is alkalosis. So, here you have metabolic alkalosis. Also, you have renal rickets, right? So, this is what you see in so this is what you see in a Bartter syndrome. Yeah, so that is what is in Bartter syndrome. Now, when you do the workup in the patient, what happens is you will see sodium and potassium will be less. Urine osmolality obviously will be less because there's a lot of polyuria, and 24-hour urine chloride will be more because it's a hallmark of tubular disorders. Here, the most important thing is urinary calcium will be lost and the magnesium will be normal. Since urinary calcium, because of the more of urinary paracellular calcium defect is present because of the ROMP and all, you will have calcium phosphate crystals and renal calculi. Now, how do you treat the patient? Hydration, NSAIDs. Now, NSAIDs, you give indomethacin, which is a COX-1 inhibitor, because they have been told to be associated with increased prostaglandins. Now, NSAIDs we give mostly in gout. We give in cases of acute gout. We also give in PDA and also sometimes in acute migraine. So here, apart from that, we give here. Next is Gitelman. Gitelman is DCT problem. This is also autosomal recessive. Both are autosomal recessive. Here the sodium and chloride and co-transport is inhibited, and this TRPM6 also is inhibited. So what happens is, again, there's a loss of water, there's loss of plasma volume. So what happens is when there's a loss in plasma water, renin and aldosterone will be GFR is less, so renin and aldosterone will be more. So you have secondary aldosteronism. So the same case, hypokalemic alkalosis. The patient is going to present the same way, dehydration, FTT. Apart from that, how do you differentiate from these two is that you can have muscle cramps, paralytic areas, cardiac arrhythmias, and also PTH will be less. So extra you can see tetany, periangular paresthesia, you can see Shovstein, you can see the uh, Kernig sign, etc. Now, it is very similar to that of thiazide toxicity. So, thiazide toxicity and Gentleman syndrome is the same. So, treatment is hydration and magnesium supplements. How do you differentiate it from barter is, like I told you, it will have the same things. Up to this, you have the same thing. Except urinary calcium will be normal here. Magnesium will be very less here. Serum magnesium will be very less. Urinary calcium is very less, and serum magnesium is. And the last one is the Liddle syndrome. Liddle syndrome is due to the defect in the collecting duct and the principal cells. It is an autosomal dominant defect. It is due to overexpression of the ENaC channels. Since overexpressed, water is more absorbed, so plasma volume will be more. So the serum osmolality will be less here. Okay. Since the plasma volume is very more, you will have hypertension. But a negative feedback, there will be less of renin, so less of aldosterone. But still you have metabolic alkalosis. And also it's a very incidental finding, and the drug of choice is to, because this is aldosterone. Why does this happen is because of aldosterone resistance or deficiency. If there is resistance or deficiency, sodium is not going to be absorbed, and but sodium is not going to be absorbed, so there will be a lot of sodium loss, but potassium and hydrogen H plus will be I'm sorry. See, aldosterone is not going to act only on the receptors. So what happens is, there will be a lot of ENaC overfunctionist, there will be a lot of salt and water retention, so hypertension will be there. Now, since of the negative feedback, renin will be less, aldosterone will be less. Still you have there is loss in potassium and hydrogen because of dehydration. And there's no dehydration, still there will be loss of potassium and hydrogen. That's why hypokalemic alkalosis. That's why it's called pseudo hyperaldosteronism. Now this is an example of low renin hypertension. There is low renin, but still there is hypertension. Usually on all the cases of renal parenchymal disorders, you will see high renin hypertension. But here you will see low renin hypertension. Now you have to inhibit the ENaC channel. So the drug of choice is amiloride. That's it.